Okay, hello everyone. Thank you very much for being here today for our program, Early Effective Antibiotic Therapy through Culture-Independent Diagnostics. We are so pleased that you've chosen to join us at this busy conference. And I have the pleasure of introducing our two speakers, the Incredible Hulk and Superwoman. So first, I would like to introduce Dr. Sandy Estrada, PharmD. She's the Vice President of Medical Affairs currently at T2 Biosystems. But before this position, she was the infectious disease clinical pharmacist for Lee Health in Fort Myers, Florida for 13 years and served as the co-director of antimicrobial stewardship, director of the ID Pharmacy residency program. In this role, Dr. Estrada led the adoption, implementation, and utilization of T2 Bacteria and T2 Candida and has published results on improved patient care and reduced hospital costs. She's also currently the president of the Florida Society of Health System Pharmacists. So thank you for joining us with Sandy. I'd also like to introduce Dr. Neil Clancy. Dr. Clancy is a physician and researcher with expertise in infectious disease. He is tenured Associate Professor of Medicine and Director of the XDR Pathogen Lab at the University of Pittsburgh. Dr. Clancy conducts collaborative clinical, translational, and laboratory research on issues relevant to treatment, diagnosis, and prevention of infections in immunosuppressing critically ill populations. His research laboratory is funded by several departments, and he has over 170 papers published in medical journals and is also the editor of the American Society of Microbiology, Canada and Candidiasis textbook. So please join me in welcoming both Dr. Estrada and Dr. Neil Clancy. We will take questions after the end of both presentations. And once again, thank you so much for joining. Please welcome Sandy to the stage.
Good afternoon, everyone, and thank you again for joining us for this presentation. So I will be leading us off today, sharing some information about T2 Biosystems, including our current molecular diagnostic panels that we have on the market, as well as some information about how these can potentially be incorporated into antimicrobial stewardship programs and help the care of patients at our institutions. Following that, we'll move into discussion of some of the clinical information available on our panels, both from my own previous institution as well as from Dr. Clancy's current practice. So there's no better way to marry the worlds of infectious disease and critical care than to talk about sepsis. And as a very popular topic at this conference, it needs no reminder that sepsis is a very prevalent diagnosis in our patients, with an overall rate in hospitalized patients of 6%, with 16% of those developing septic shock and 55% requiring ICU level care. While the overall mortality rate in hospital for sepsis is about 15%, it's even higher at 25% for those diagnosed in the hospital versus those who are admitted with sepsis at about 13%. So due to these high mortality rates, the Surviving Sepsis campaign has encouraged the prompt initiation of broad-spectrum antibiotics, specifically given within 1 hour of identification of both sepsis and septic shock. It is recommended that empiric broad-spectrum agents be chosen with antimicrobials that are likely to cover all pathogens suspected in a particular patient case. We know that time to appropriate therapy impacts survival, and this data from Kumar is one of the prime driving forces for these recommendations that we must get empiric therapy on board as quickly as possible in our most critically ill patient population, which is those with sepsis and septic shock. While every hour in delay of time to appropriate therapy causes a decrease in survival by about 7.6%. There's also data that the relative odds of death increase by 4% during bacteremia. So those patients who may not have septic shock but are still bacteremic. So in both scenarios, there is still that need for rapid therapy. While we see the decrease in time to survival based on how long it takes to get empiric therapy on board, we also see that when we look at the blue lines representing cumulative effective antimicrobial initiation, it takes to over 12 hours to get above that 80% mark of effective therapy. So we have some room for improvement in getting the appropriate therapy for our patients. Reducing time to effective therapy, in addition to having a potential mortality benefit, has also been shown to reduce length of stay up to 8 days. So when we think about our current process, this diagram shows how we currently operate with regards to empiric antibiotic therapy, as well as blood culture diagnosis. So right now, when a patient presents with the need for a blood culture, in this case, let's say a septic patient, the blood culture is obtained, sent to the microbiology lab, where that culture is incubated. On average, about 37 hours later, a positive blood culture is resulted. Could be less, could be longer, but anywhere between 1 to 2 days is usually for most pathogens when we start to get back information. At that point in time, we get a gram stain. Then, following the gram stain, we get a species identification, and then ultimately antimicrobial susceptibility testing. By the time all of this is done, we're usually somewhere in the 72-hour mark from time 0 of patient presentation. So thinking about the concurrent antibiotic therapy, we've started empiric broad-spectrum antibiotics between the 0 to 1 hour of presentation. Somewhere on day 2, we get a gram stain back. We may be able to make decisions on therapy, or we may not based on that. Another day later, we get species-directed therapy. This is really our first opportunity to say, okay, maybe we can start streamlining or targeting our antimicrobial therapy based on these results, and then we do so even further once we have susceptibility testing back. In a meta-analysis of 70 studies, empiric antibiotic therapy was found to be inappropriate in 46% of patients, with appropriateness defined purely as whether there was susceptibility for the pathogen. So not necessarily the best choice of antibiotic, but purely just one that had susceptibility. So again, we have an opportunity to improve in our selection of empiric antibiotics, as well as the changes we make over the first couple of days. However, the proportion of patients on effective therapy once the species is identified has been shown to be over 90%, demonstrating that knowing the species even before susceptibility testing can have an impact on appropriate therapy for our patients. So where do rapid diagnostics fit into this picture? At my previous institution, as I'm sure many of your own, we implemented several different rapid diagnostic tests in an effort to be able to get these answers sooner, to know what was or was not infecting our patients so that we could make more informed decisions about which antimicrobials to utilize in those patients. So rapid diagnostics have become an integral tool for many antimicrobial stewardship programs across the country, and many are still evaluating and trying to see exactly where is the best place for these to fit into clinical practice. But what we've seen now time and time again in clinical publications is that when you couple a rapid diagnostic test with an antimicrobial stewardship program, then we in fact can empower clinicians to make appropriate and timely changes to their patient care. In other words, a rapid result is only as good as a rapid action that is taken on that rapid result. And so the two go very well together. Ultimately, doing this can lead to improved patient outcomes through optimization of antibiotics, decreased time to effective and optimal antimicrobial therapy, and at the end of the day, cost savings with antimicrobial use, as well as reduction in length of stay and associated hospital costs. So T2 Biosystems currently offers the only FDA-cleared direct from blood test for bloodstream infections. We have both the T2 bacteria and the T2 candida panels. Again, FDA cleared in the United States as well as CE marked in Europe, and providing detection without the need to wait for a blood culture to become positive. This is a CLIA moderately complex assay approved to be used in the routine clinical laboratory and gives a full answer on species ID 3 to 5 hours after presentation of the patient. So again, not requiring that wait for blood culture. A 4 ml sample of patient blood is obtained, loaded directly into our instrument, and again, between 3 to 5 hours later, we are provided with a result. What type of result is provided? We have two different panels currently available. The first is the T2 bacteria panel, and it currently detects Enterococcus faecium, Staphylococcus aureus, E. coli, Klebsiella pneumoniae, and Pseudomonas aeruginosa. We also have the T2 Candida panel, has been clinically available on the market for several years now with quite a bit of data supporting it, and it has the top 5 species of Candida causing infections in the United States, including albicans, tropicalis, krusei, glabrata, and peropsilosis. Both of these tests offer sensitivities in the 90% and specificities in the 98 to 99% range in clinical practice. So why were these 5 pathogens chosen for our bacteria panel? These pathogens represent 50 to 70% of all bacterial infections, but specifically about 90% of ESKAPE pathogens, being those that are concerning due to not only their prevalence, but also their high rates of mortality and antimicrobial resistance. Just to point out a few specifics, Enterococcus faecium being currently about 60% resistant to vancomycin, Staph aureus being the current most common cause of bacteremia with a 5 times higher rate of in-hospital death when it is present, and then our gram-negative pathogens all being associated with both elevated mortality rates as well as elevated resistance rates to various antimicrobials. Again, just to reiterate one more time, because this is really a paradigm shift of testing in the laboratory. The current process on the bottom, patient presents, blood culture is collected, incubates in the lab. Anywhere from 1 to 5 days later, we get, as we mentioned, a species ID. And then after that, we get more information about that pathogen. If you look on the top of the diagram, in this particular scenario, when the patient presents at the same time as the blood culture bottles being drawn, that 4 ml tube of blood is sent to the lab, placed on the T2Dx, and 3 to 5 hours later, a result is provided for our pathogen with a greater than 90% sensitivity versus blood culture showing about a 50 to 65% sensitivity for that first set of cultures. In the laboratory, there may be other rapid molecular technologies available as well that can help lead to species ID, and these are all performed after that blood culture is positive. So again, being the differentiator for T2 and our bacteria and Candida panel being not having the need to wait for that positive culture. So if we take a look at the similar algorithm that we saw before, now we see that with the insertion of the T2 test, we can have this result within the first 5 hours of presentation. So while we would normally still be waiting for a blood culture to exhibit growth, we now have information that could help us start to consider making changes to our antibiotic therapy for our patients. I mentioned that our T2 Candida panel has been on the market for several years now, so we have quite a bit of data supporting its utilization. Just giving you a few high points here, and then we'll see a little bit more of that in the second part of the presentation. But faster time to results, specifically 5 hours versus 72 hours, enabling an 8-fold reduction in time to appropriate therapy, 5 hours versus 44 hours, again, for these candidemic patients. And we already spoke about a proven clinical sensitivity of between 90 to 100% for bacterial and fungal pathogens across more than 5 independent studies and over 300 confirmed infections. Our specificity is also very high at an average of 98.5%, again, from several different studies, over 3,000 patients in more than 15 institutions. This leading to an estimated negative predictive value of greater than 99%, allowing confidence in making decisions about antibiotics, that if in fact the test is negative, that consideration for not having the pathogen and discontinuing appropriately antifungal therapy can be considered. In the implementation of T2 Candida, one hospital from Henry Ford demonstrated a $2.3 million in annual hospital cost savings, again, primarily from length of stay reduction in addition to reduction in antifungal expenditures. 2 independent studies also showed a 7-day length of stay reduction in ICU patients and pharmacy savings of between $195 and $280 per tested patient across multiple studies. So before we move into some of the clinical data, just wanted to give you a preview of what we have up and coming. So I mentioned already our T2 Candida and our T2 bacteria panels. We also have a T2 Candida auris assay that is available for research use only in the United States. And we have in development resistance panels, including our T2 Carbaresistance Plus that has several carbapenem resistance genes, and our T2ARX in development that has additional resistance markers such as gram-positive resistance and ESBL resistance genes as well. So pay attention as the year progresses, and we may have more information to share on some of these exciting new developments in the antimicrobial resistance gene world. Also, on our T2 bacteria assay in Europe, we have, in addition to the 5 pathogens that I already discussed, Acinetobacter as an additional pathogen on that panel. So now we'll move into the clinical data supporting the utilization of T2 bacteria from my own personal experience, and then we will transition to the second half of the presentation. But when I was still at Lee Health in Fort Myers, Florida, I was the antimicrobial stewardship pharmacist there, and we were they still are, a large community health system with 4 acute care adult facilities covering more than 1,400 beds, as well as a freestanding pediatric hospital. And my former resident, Emily, who happens to be in the room, had the opportunity to participate in an evaluation of T2 bacteria when it was still RUO before it was FDA approved. And the purpose of her study was to evaluate the utility of T2 bacteria in optimizing antibiotic therapy in sepsis patients and guiding overall antimicrobial stewardship. The primary outcome of the study was time to organism identification using T2 bacteria panel compared to standard blood culture. And the secondary outcomes included percent concordance of T2 bacteria results with blood culture results, as well as the total number of potential antimicrobial stewardship interventions, including both escalation and de-escalation opportunities. This was a single-center prospective observational study, and patients were enrolled from the emergency department with informed consent from November of 2017 through March of 2018. Patients were enrolled in the study if they presented to the emergency department of one of our 4 facilities and had suspected sepsis, as well as a news or national early warning score greater than or equal to 7 or 1 red score, or they could be included with a news of greater than or equal to 5 if they had neutropenic fever. The considered patients were consulted and informed consent was obtained for enrollment, and this was obtained by a protocol-trained pharmacist. They were excluded from the study if they were less than 18, pregnant, incarcerated in police custody, receiving IV antibiotics prior to admission, unable to consent, or if there was an invalid result. Blood samples for T2 bacteria and for blood culture were obtained concurrently from each patient enrolled, and the T2 bacteria sample was hand-delivered to our on-site laboratory. The results were interpreted by a protocol-trained pharmacist, and results supporting antibiotic de-escalation were recorded as potential interventions, but no adjustments were implemented due to the observational nature of the study, being that the product was still not FDA approved at the point in time of the study. 25 patients were initially enrolled, with 23 being available for the final analysis. Mean age of the patients was 65 years old, with a little over half being male. About 40% had recent antibiotic exposure. Of note, as antibiotic exposure can impact the sensitivity of blood culture. However, antibiotic exposure does not impact the sensitivity of the T2 bacteria assay. We looked at the source of infection for these patients presenting with sepsis, and the majority of patients in the study did have sepsis of undefined source at the time of enrollment into the study. At the end of the study, there were 11 patients with positive results for a total of 18 organisms. In the T2 bacteria side, there were 8 patients with a positive result for a total of 10 organisms. And on the blood culture side, there were 7 patients with a positive result for, again, 8 possible organisms. This slide nicely depicts the organisms that were found. So There were 4 isolates of Staph aureus and 1 E. coli that were confirmed by both blood culture and T2 bacteria, meaning that there was 100% agreement for included bacteria. T2 was able to find all of the pathogens that blood culture found of those on our panel. The 4 isolates that blood culture found that T2 did not find were Staph and Strep species that are not currently on our panel. In addition, T2 bacteria identified an E. coli, an Acinetobacter, a Klebsiella, and 2 Pseudomonas aeruginosa that were not identified by blood culture. So looking at our outcome of stewardship opportunities for intervention, a total of 36 opportunities for de-escalation were identified. And we approached this by looking at, could we de-escalate coverage for Staph aureus if Staph aureus was not present? And could we de-escalate coverage for Pseudomonas if Pseudomonas was not present? De-escalation opportunities were assessed based on the patient history, the source of sepsis, including the recommended antibiotics for that source per national and institutional guidelines, the antibiotic history of the patient, and local antibiogram information. I'll conclude these results by sharing with you 2 case studies as examples of how these data were interpreted. The first case was an 84-year-old male with diabetes, prostate cancer, and end-stage renal disease on hemodialysis. He presented to the emergency department after experiencing chills during dialysis. He had not been feeling well for over a week, complaining of weakness, nausea, and vomiting, was found to be febrile with an elevated lactic acid and a negative urinalysis. The patient was started empirically on vancomycin and piperacillin tazobactam, as many septic patients presenting to our emergency department are. Culture and T2 were obtained. Blood culture was positive for Staph aureus on day 3 of admission, and piperacillin tazobactam was discontinued on day 3 as well, based on the blood culture result. The paired T2 result was also positive for Staph aureus approximately 4 hours after presentation of the patient, negative for the other organisms on our panel. So in analyzing this result, the same decision could have been made to discontinue the piperacillin tazobactam. However, that decision could have been made up to 2 days earlier on day 1 after Staph aureus was confirmed as the causative infection. In the second case, this was a 53-year-old immunocompromised female with recent history of surgery to drain an intra-abdominal abscess. She presents to the emergency department 8 days postoperatively with fever, chills, and abdominal pain. Started on empiric antibiotics and admitted to the hospital. Her empiric antibiotics were linezolid, aztreonam, and metronidazole. Due to a penicillin allergy, piperacillin tazobactam was not chosen, and linezolid was chosen due to her morbid obesity and suspected challenges with vancomycin dosing. She had blood and urine cultures that were both negative throughout the duration of her hospitalization, so she continued on empiric IV therapy for 5 days and then was transitioned to 2 days of oral antibiotics after she had clinically improved prior to discharge. The T2 bacteria result was positive for both E. coli and Pseudomonas, negative for Staph aureus, Enterococcus, and Klebsiella pneumoniae. So in this scenario, we would have known on day 1 that the patient did not have Staph aureus, so therefore did not have MRSA, and linezolid would potentially not be necessary for this patient and could have been considered for discontinuation after the first dose once the T2 bacteria result was available. The patient's therapy then could have been streamlined to cover the E. coli and the Pseudomonas and potentially other anaerobic pathogens, as the suspected source was intra-abdominal, and anaerobic pathogens are not detected by the T2 bacteria panel nor frequently grown on blood culture. In conclusion of this small early study for the results of T2 bacteria at Lee Health, we found that we were able to provide final results within 4 hours, detecting a greater number of pathogens in patients that would have otherwise been culture negative, potentially allowing for treatment decisions on patients in this culture negative sepsis scenario to be implemented much earlier. And we found numerous opportunities for stewardship intervention on these patients secondary to the T2 bacteria findings. So I'd like to thank you for your time and attention listening to my part of the presentation, and would like to transition now to Dr. Neil Clancy to share his experience with T2 Diagnostics.